Okay. So we had a couple of questions that seem quite practical, which about biomarker testing. And the related one is how long does it take to get biomarker testing results? And should you wait for your treatment to start until you get the results of biomarker testing?
Yes, very practical and important question that I get asked often by oncologists as well. And I'm glad that this question is asked because the reality is that often there is a wait time for all the biomarker testing results to come in. And results may also not always come in at the same time. They roll in. So PD-L1 result may come in first before the next generation sequencing results come in to look at gene alterations. But we've learned that if a patient starts on immunotherapy, let's say the PD-L1 result comes back high and NGS results have not yet come back, but based on the high level PD-L1 result, a patient starts on immunotherapy. Then let's say the NGS testing comes back, shows a EGFR mutation. In that case, you would want to switch to EGFR targeted therapy or EGFR inhibitor. But what we've learned is that when there's prior immunotherapy exposure and then a switch to targeted therapy happens, there can be increased risk for certain toxicities. For example, with EGFR inhibitor osimertinib, if there's prior immunotherapy exposure, there can be increased risk of pneumonitis, meaning inflammation in the lungs that can lead to significant shortness of breath or cough. With other targeted therapies, we've seen that after prior immunotherapy exposure, there can be significant liver toxicity or really diffuse severe rash to the point of requiring hospitalization and sometimes intensive care unit stay as well. Because of this, our recommendation is to make sure that the gene testing result, the NGS result, is available to know whether you are a candidate for targeted therapy or not before immunotherapy is initiated, even if that PD-L1 result has already come in. So what does that mean if a patient is suffering from symptoms of lung cancer like pain or shortness of breath and really just needs to start on treatment right away and biomarker testing results are not yet available? It's really hard to just sit and wait in those circumstances, right? And it's not the right thing to do either. So in those circumstances, what we commonly do is to go ahead and treat the patient with a dose of chemotherapy without immunotherapy, because then what we do is we minimize that risk of added toxicity, but we are allowing at least one cycle of chemotherapy to go in and try and temper the cancer burden. Often, the first chemotherapy we reach for patients with non-small cell lung cancer is given every 3 weeks. So before the next dose is due, typically we get all the biomarker testing results back so that after that first dose, before the second dose of chemotherapy is due, we're then able to say, okay, now all the results are available. Are we going to pivot to targeted therapy? Are we going to pivot to immunotherapy and so on and so forth?
Okay. And in that case, if you did get back a result that the patient had an EGFR mutation, do you switch or is that additive with chemotherapy or how does that work?
Gosh, that would have been, my answer would have been very quick if you asked me this question a year ago. Today, it's quite a sophisticated question. So a year ago, I would have said, absolutely. So after the dose of chemotherapy, if the gene testing comes back showing an EGFR mutation, switch to the EGFR inhibitor. And right now, the standard first EGFR pill to go for is osimertinib. The reason it's a very nuanced question today is because just over the past year, there have been a couple large clinical trials that have been reported out where they looked at the first-line treatment option for patients with advanced EGFR mutated lung cancer. And one trial, for example, looked at chemotherapy together with osimertinib compared against osimertinib by itself. And there was a benefit in progression-free survival. It was a positive trial. And so now chemotherapy plus osimertinib is also considered a standard initial treatment option for this patient population. So now that discussion is more complicated For if you have metastatic EGFR mutated lung cancer, your doctor will probably discuss both options, and then they'll tell you, okay, because of these reasons, let's go ahead with osimertinib alone, or because of these reasons, let's go ahead and do osimertinib together with chemotherapy. So it's a lengthy discussion, but regardless, if the biomarker testing shows an EGFR mutation, then yes, you will be shifted towards EGFR directed treatment algorithm.
Okay, well, I'm glad to see all this progress is being made.